Yeah, I'll be discussing a long case. 52-year-old gentleman, Mr. A, presented with complaints of imbalance to walk with swaying to the right side, incoordination of right hand, with double vision and drooping of right eyelid, followed by left-sided weakness. 4 days ago, these symptoms started. It was sudden onset.
Yeah, Pramod, we'll stop here. Just ask the audience, what do you guys think? Double vision, imbalance while walking, followed by drooping of eyelid and weakness. What do you think? So sudden onset focal neurological deficit, so it could be a stroke. Then double vision tells you cranial nerves are involved, so maybe cranial nerves are involved. And imbalance tells you cerebellar connections are involved, so maybe brainstem, lateral. The confusing thing is there's also weakness. So maybe the straightforward approach, so it tells us it's brainstem, whether it's medial or lateral or started laterally going on to medial is something that we can't really clarify just based on chief complaint. So we need to look into a more detailed history to clarify. Yeah, go ahead.
So coming to the history of the illness, patient was apparently well till 9 a.m. in the home. He was sitting in a chair and watching TV. When he tried to go to the restroom, he was not able to maintain balance and have been having swaying to the right side. So he had the tendency to fall. So he tried to grab the door on the right side of him. So when he tried, he was not able to reach and he had difficulty in reaching out for the door. So he had to call his wife for help and she had supported him to go to the washroom. So when he went into the washroom, while he sat on the commode and while he was using the tap, he was able to see that there were 2 taps which were clearly separated sidewise and he was unable to make out which is the original one. But somehow he was able to hold the tap and he was able to turn it and close and utilize the tap. So at that time when he tried to get up from that position, he was having difficulty in getting up, where he had some mild difficulty in lifting the left hand. So when he came out of the washroom with the help of wife noticed that the right eye appeared to be small compared to the left one, and when she had asked the person like why it was small, he was unaware of the deficit. So he tried to open the eyes wide and stare and look, but he was not able to do so, and he tried to rub the right eye. So when he tried to rub the right eye, then he noticed that the double vision which was there previously in the washroom, it was disappearing when he tried to completely close and rub it. So he was supported back to the bed by wife, and she had made, like, she suspected that there was something wrong with him because of all these symptoms. So she tried to arrange an ambulance and make him shift to the hospital. When she came back to him, she noticed that he was not moving the left leg and he was not able to get out of the bed. So he had to be carried to the ambulance and then later to shifted to the hospital. So he was able to communicate with her very properly. He was able to understand and reply, and there was no slurring of speech noted, and he did not have any no vertiginous sensation. He did not have any numbness or paresthesias over the face or body, and there was no nasal regurgitation. And preceding, no fever, no headache, and he did not have any episodes of loss of consciousness, or he did not have any similar complaints in the past. So at this, based on the history, we can tell that he has got cranial nerve involvement because he has got double vision with images being separated horizontally. By that we can tell that it can be either because of involvement of medial rectus or lateral rectus, which is 3rd and 6th nerve. So along with that, he has also got the long tract symptoms like incoordination because of the cerebellar connections and weakness of the limbs, which is because of the corticospinal tract involvement.
So can you elaborate on the double vision, Pramod? So how can you localize the double vision? So
yes.
Is it because of midbrain involvement or is it because of pontine involvement? Both can cause double vision.
Yes. In this patient, the history, he was telling that he was having double vision on looking at the tap which was placed by the side of him. So it is double vision to near objects where your medial rectus need to act to see the near objects. So he was having double vision at that point. So it tells that 3rd cranial nerve was involved. So
first thing you would want to ask in double vision is whether it's horizontal separation of images or vertical separation of images. So if vertical separation of images, what will you think of? If it's horizontal, what will you think of?
if it is horizontal separation, it can be like a third nerve or a sixth nerve involvement, sir.
Yeah.
If it is vertical separation, it would be because of fourth nerve involvement.
Fourth nerve was skew deviation.
Skew
So both of
deviation.
these can cause vertical or an entrapment rarely. So if it's horizontal, that means you can't failure to adduct. That means third nerve palsy can cause horizontal separation, or failure to abduct, that is sixth nerve palsy. Both can cause double vision with horizontal separation. How do you differentiate between both?
In case of third nerve, it will be for the near vision. Like nearly placed objects, he'll have double vision more.
One condition where you use bilateral medial rectus is convergence. So if you're looking, diplopia is more for near objects, that means failure of conversion, that means medial rectus is involved. So if there's diplopia for nearby objects, you'll think of third nerve palsy, and diplopia for distant objects, you'll think of sixth nerve palsy. So here you think this is because of?
Third nerve involvement,
Yeah.
because he had.
So any other thing to say third nerve?
He has also got ptosis, drooping of the right eyelid.
So mind you, this is history, so drooping of eyelids may or may not be reliable, or maybe it's a Horner syndrome, maybe it's partial ptosis. So even with diplopia, even without the ptosis, you can still come to the same conclusion. So yeah, go on. So you think it's localized to which part of the brainstem?
Because of double vision involvement, we suspect that it could be brainstem, in the brainstem, midbrain, sir.
Yeah, so midbrain, especially mainly because of the diplopia as well as the third nerve palsy, and long track symptoms. Is it medial or lateral, or maybe starting laterally coming medial? So
Because he has got both incoordination of incoordination as well as weakness, where incoordination will be because of the cerebellar connections, which will be placed laterally, and weakness is because of the corticospinal tract involvement, which are located medially. He might have both like medial and lateral, both
but
might
here
be involved.
the cerebellar signs are on one side and the weakness is on the opposite side. Is there any place in the brainstem where you can get unilateral, bilateral, ipsilateral kind of cerebellar signs?
In the it can be possible in the midbrain with the involvement of the
The
superior
exception
cerebellar.
to the lateral rule of cerebellar signs is in the upper part of the midbrain, where there's decussation of the
Decussation.
superior cerebellar peduncle, where you can get medial lesions can cause cerebellar signs. So, yeah, go ahead with the examination.
So general examination, his vitals were stable and he did not have any peripheral stigmata of TB, no neurocutaneous markers, and no skeletal abnormalities was also there. So coming to cranial nerve examination, the first and the second cranial nerves were normal. Third, fourth, sixth cranial nerves, pupils were reactive, equal, 3 mm, and accommodation reflex was absent. He also had right eye ptosis with adduction impairment.
You can go to the video and
Yes. So in this image, we can see that the left eye is open, whereas the right eye, the drooping of eyelid can be noted in this. And on examination,
keep describing the video.
yeah.
He's
So
trying to
when he was asked to look towards the right side, he was able to look, and when asked to look towards the left side, we can see that the left eye was moving towards the left side, whereas right eye is not moving. So the right eye he is not able to adduct, whereas the left eye is having abduction nystagmus in the left eye.
So the right eye is not adducting and the left eye is having some nystagmus.
Yes.
is it? And if you do an oculocephalic, that was absent. So what do you think this is?
This is a internuclear ophthalmoplegia.
So if it's an internuclear ophthalmoplegia, so it could happen anywhere along the MLF. So it could be either in the pons or in the midbrain. So how do you differentiate between a midbrain INO, which is an anterior INO, and a posterior INO, which is in the pons? So
In case of anterior INO, the vertical gaze also would be affected, and the convergence would also be lost.
So we looked for convergence and upgaze. So in him, was it normal or impaired?
Vertical gaze was impaired, sir, in him.
So that way the localization will be to the midbrain.
Midbrain.
Consistent with what we found in our history. So yeah. Go ahead. Just mention the positive findings alone in the rest of the.
He has got also sensory impairment in the right side of the face, involving the V1 to V3 distributions, and the corneal reflex was also absent on the right side. The other cranial nerves were normal with examination. Coming to the motor examination, the power on the left side is 3/5, and sensory, as I have described already, right sided sensations were reduced. Reflexes were normal. And cerebellar examination, he had right-sided cerebellar signs in the form of dysmetria and dysdiadochokinesia were noted, and even the heel shin as well as the past pointing was noted in the right side, right upper limb as well as right lower limb. And he was not able to, as he had weakness, that also could have contributed, but he was having more of incoordination on the right side. So skull and spine were normal. So coming to the summary of the case, 52-year-old gentleman presented with sudden onset diplopia with drooping of right eyelid with right-sided incoordination and left-sided weakness. So on examination, he had right-sided ptosis with right internuclear ophthalmoplegia, right hemifacial sensory loss, right-sided cerebellar signs, and left-sided hemiparesis. So based on these symptoms, the clinical localization would be multiple cranial nerve involvement in the form of right third, fifth, as well as in the form of internuclear ophthalmoplegia, and long tract signs in the form of weakness, left-sided weakness, and right-sided incoordination, which is because of the cerebellar connections. So brainstem would be the localization in this case, and in the brainstem, midbrain we are thinking because he has got a double vision with horizontal separation of images to the near vision. So third cranial nerve possibility was considered. So that's why midbrain is the localization in him. It can be both medial and lateral.
Lateral starting going on to medial, or it could be only a medial one where there's an exception to the rule where the decussation of cerebellar peduncle. So which do you think it is? So
it was like medial started and then had a lateral involvement. Because initially he had only symptoms of incoordination, later developed.
It was a stepladder kind of pattern. It evolved over some time.
Yes, sir.
So it could, always possible we try to have a single localization. So if you want to say a single localization, is there any single site?
Midbrain, medial part of the midbrain.
That itself can, when that can explain all findings, then you can say only that. So the other possibility is if it's more than one side, it's both medial and lateral, or it could be even bilateral depending on, all of these lesions can extend beyond one vessel territory. So going on to imaging.
Yes, sir. So we have done a stroke protocol because it was sudden onset. Vascular etiology was considered to be the first possibility, and it was showing a diffusion restriction in the medial part of the midbrain as well as on the lateral part.
Yeah. So if you can see, the upper cut actually shows that the pyramidal tracts are involved, causing the contralateral weakness, and the medial part you can see that that's where the decussation of the superior cerebellar peduncle is. So that's why he's got ipsilateral cerebellar symptoms and contralateral hemiparesis, because the pyramidal tract is involved, the other side, because it's not yet crossed.